everyone, and welcome to the One Society Network Seminar Series number 2. And really, the focus of this series is looking at areas One Society might not have fully explored, but are, we think, very relevant to the research we're doing. And I think the talk today perfectly starts off that discussion. My name is Ellen Rafferty, and I will be facilitating the session. And I would like everyone to join me in welcoming our presenter, Dr. Lisa Richardson. Dr. Richardson is an Associate Dean of Inclusion and Diversity and an Associate Professor in the Faculty of Medicine at the University of Toronto, and practices general internal medicine at the University Health Network, where she's an education researcher at the Wilson Center. And today's topic is wise practices for reconciliation. And before I begin, just a brief some details about housekeeping. So everyone will be muted throughout the webinar, but feel free to submit your questions through the Q&A function. And just remember, the Q&A function is slightly different from the chat function. So if you have any general comments, they're welcome through the chat, but we welcome any questions through the Q&A. And we'll save some time at the end of the presentation to really discuss these important topics. So thank you again for joining us, and I will hand it over to Dr. Richardson.
Thank you so much, Ellen. And Ellen and I were just talking prior to starting about how we want to make sure that we have enough time for questions. So some of the slides I will just move through very quickly, or may even skip over. But because I really want to make sure we have time to dig into some of this content. And the way in which I'm approaching it is to actually give you some key concepts and background material that will help you in your work, both in modeling and in economics and in researching, across cultures and with Indigenous communities, and how to do that in a meaningful way. I know that you will be have access to the seminar of the OCAP training program next week, so I am not going to be specifically delving into the OCAP principles. Of course, all of this content is background material to help prepare you for that. I wanted to acknowledge Nadia Quandabens and Redworks Photography or Imaging. Anyone who has seen me present before knows that I do use her work, and thank her for the beautiful photographs. This content also builds on the work of a network of Indigenous health leaders with whom I've worked, and I wanted to acknowledge all of them. And also, you never get to do any of this work without tremendous support from family, community, mentors, elders, knowledge keepers. And so as a part of modeling these wise practices, I do try to ensure that I'm amplifying and acknowledging the voices of those who have supported me to be here. I'm going to introduce myself and speak about some foundational frameworks for the work of reconciliation in research, in healthcare, in education institutions, and everything that we do. A little bit around how we got to where we are here, around thinking about understanding colonization as the primary determinant of the health gaps currently experienced by Indigenous peoples, including with respect to COVID. And then this concept of wise practices, which Brian Calliew and Cynthia Wesley Esquimalt talk about in a lot of their community leadership work, which I think is really important. And then we'll have time for Q&A. So to locate myself, acknowledging that I'm currently in Toronto, Takaranto, on the traditional territory of the Mississauga of the Credit, the Haudenosaunee and other Anishinaabe peoples. Originally, the Wendake peoples were also here, and currently there are people from across Turtle Island who reside in Toronto. And traditionally, it was actually a meeting place of nations, which I think reflects how Toronto continues to be now a meeting place for people from across the globe, and how we are trying to model living together with respect and inclusivity. My family, my background is mixed. Obviously, as per my appearance, I have European white ancestry on my father's side, and on my mother's side, Anishinaabe ancestry. She is from a community called Killarney or Shebanoning, which is actually not recognized as a reserve. And so the people in the Indigenous peoples in Shebanoning are registered with surrounding First Nations, and we're just going through the process because of the urgent need for documentation of identity of registering for status, and that will likely be with Wanapitei First Nation, where many of our relatives are actually located just outside of Sudbury, Ontario, and close to our traditional territory. I also have great privilege in my profession. I work as a physician. It puts me into a high socioeconomic status. Based on that, I've come from a very supportive family with also with privilege, and I am identify as a person who does not have a disability. I am in a marriage with a man, and I have 2 children. So just all of those aspects of locating myself and the privilege that I have based on having many dominant identities, in addition to being a mixed blood person. That act of actually locating myself is an act of what I call reflexivity. Reflexivity, as those of you who have social science training will know, is about locating yourself, not just physically, but actually understanding your identity and how it contributes to the way in which you interact with the world. What are the assumptions that you make? What are the biases that you bring? What are the strengths that you bring based on your culture and your background? So that process of understanding that location is really, really important, particularly when you're doing work with communities who have been structurally marginalized or with Indigenous people. So I urge you to consider that, what your own social location is, as you enter into this work. The first foundational framework that I wanted to share with you related to Indigenous peoples in Canada is the UN Declaration on the Rights of Indigenous People. And this includes, it's called UNDRIP for short. This includes the right to be self-determining. And the right to be self-determining is the right to determine and develop priorities and strategies for exercising the right to development. And it specifically does include health programs and it includes economic development as well. With respect to healthcare, the UN Declaration on the Rights of Indigenous People includes the right to traditional medicines and health practices, as well as access to all health services. So it is not an either or. This is a situation where Indigenous peoples have the right to both pursue their own cultural healing practices and also to access services in hospitals, in clinics that are not Indigenous. And really what we're all fighting for is the equal right to the enjoyment of the highest attainable standard of physical and mental health. The second foundational framework for you to consider in the work that you're doing is that of reconciliation. And I want to reiterate here and articulate these principles of the TRC, the Truth and Reconciliation Commission, which are to remember that reconciliation requires constructive action to address the legacies of colonialism, and that the purpose of reconciliation is to create a more equitable and inclusive society by closing the gaps in social, health, and economic outcomes. Thirdly, that all Canadians are treaty peoples. So whether you are an Indigenous person or whether your ancestors came here 500 years ago or 10 years ago, your family came here or you arrived more recently, you are coming into an environment where treaties have been signed or where land agreements have been made, and we all share the responsibility to work towards reconciliation. Lastly, recognizing that reconciliation is a process of healing. And this process of healing of relationships that were disrupted by colonial governments requires that we understand the truth of this work and that there be some public truth sharing. The next foundational framework that I want to share is that of the inherent rights of Indigenous peoples. And these are protected in the Canadian Constitution. What one needs to understand, and they're referred to in the Constitution as Aboriginal rights because we've had changes in naming and nomenclature through the years, from Indian, Native, Indigenous, Aboriginal, and now most inclusive Indigenous. So Aboriginal rights under the as protected are collective rights which flowed from the Aboriginal people's continued use and occupation of certain areas. They are called inherent rights because these rights have been practiced and enjoyed by Indigenous people since before European contact. So they existed before the creation of the land now known as Canada and before the signing of treaties and other agreements. Because each First Nation historically functioned as a distinct society, there is no one official overarching definition of what these rights are. So these rights actually are generally understood to be inherent, but they are acted upon as through legal actions. For example, the inherent right to self-determination for health was one that was upheld several years ago when a young Indigenous woman or girl, her family was taken to court for because they chose to pursue traditional Indigenous medicine rather than chemotherapy for her cancer. And the physicians and healthcare team actually wanted to remove her from her family and place her into child welfare so that they could give her the treatment that they felt would be life-saving as per the evidence. And the family and community actually said, we are practicing traditional Indigenous medicine here. And when that went to the court, the right to traditional medicine was upheld. So she was not removed from her family. That's an example of how these rights actually get delineated often through legal action in courts. Access to hunting and fishing rights are another example. In general, though, although they're not specifically outlined in the Constitution, they do include rights to the land rights, to subsistence resources and activities, the right to self-determination and self-government, and the right to practice one's own culture and customs, including language and religion. This understanding of Indigenous rights is really important as they exist in Canada, because I often will hear, well, how is the situation for Indigenous peoples different? Why are there specific programs, etc.? First of all, I explain that in order to achieve, because Indigenous health inequities have emerged due to constitutional or legally or judicially instantiated differences, such as the Indian Act that leads to a different form of health care, different access to medications, etc. The only way in which we can actually redress those inequities is to understand that we must dismantle or change or challenge these policies and processes, and in some cases, legislation. And so that is why one must have often specific programs and pathways to achieve Indigenous health equity or self-determination. And then the caveat or the second component of that is these rights are actually constitutionally protected. So there is a distinction for the rights of Indigenous peoples in Canada. They have not been granted from external sources, but are a result of Aboriginal people's own occupation of their home territories, as well as ongoing social structures and political and legal systems. And so they are separate from rights afforded to non-Aboriginal Canadian citizens under Canadian common law, and they are protected under Section 35 of the Constitution. The next foundational framework is more of a theoretical one. So the first three were legal or policy frameworks, and the next ones that I'll be speaking to you about are theoretical and pedagogical frameworks. So the first one is anti-racism and anti-colonial practice. And I'm point you to Dr. Elizabeth McGimmon and Josephine Otoa's book called Anti-Racist Healthcare Practice. It's very concrete and a nice way to enter into this material. They published it in 2009. They're both educators at Dalhousie in the Faculty of Social Work. I believe they're both in social work. I know Dr. Otoa is, and it's a really helpful text. And they speak about the three processes that can work in synergy to guide anti-racist practice, which is one, to see the paths from stereotype to oppression. So number one, to see the stereotype, and then to link that with how it leads to differential treatment. For example, if an Indigenous person is stereotyped as, Indigenous peoples are stereotyped as being non-compliant with medications or not adherent to medications, how does that then lead to them receiving, and this was a case I had to intervene in recently, where a patient was actually not sent for an angiogram because the statement that was made was, well, they will not adhere to antiplatelet therapy, to the medication they would need if they were to have a stent placed. Therefore, we're not going to offer it to them anyway. So a blatant example of stereotype leading to oppression because the patient received a second tier of care as a result of that. Then when one understands these patterns and how they are playing out, how do you actually see the link to policy and act to change that? Those are the key principles to me around really acting for change around and enacting anti-racist and anti-colonial practice. Anti-racist and anti-colonial practice also means understanding that colonization is the major social determinant of health for Indigenous people around the globe. In other words, the current inequities that exist in health for Indigenous peoples, but also the other inequities that exist in the justice system, in the education system, related to economic development, etc., are the result of colonization and its constructs, including the legislation, structures, policies, and processes that support that. So it's very, very important when we speak about Indigenous health, we talk about the most important distal determinant of health, social determinant of health is colonization, and all of the resulting ones, housing infrastructure, food security, and other factors that link with the current state of gaps in Indigenous health are downstream effects of colonization, which include, for example, being forced into racially segregated communities known as reserves, which have, are now extremely important for protecting land and from community. But as we look at the fact that land was taken away from Indigenous peoples and people were forced into these segregated communities, the downstream effects around healthcare are so significant. So this is because Indigenous peoples, families, and cultures and identities were severely disrupted by actions of colonial and Canadian governments, such as the Constitution of 1867 and subsequent Indian Acts that legalized the removal of First Nations communities from their homelands to reserved lands that were controlled by the government of Canada on behalf of, quote, Indians. And the Indian Acts that followed, 1876, 1880, 84, and later, were subsequent legislation to continue to contain and control Indigenous peoples. For example, Indigenous peoples lost their right to their status if they were to go to a higher education institution, if they were to join the army, if they were to own a business, one had to give up Indigenous status. And so this is just one example of an assimilatory policy that aimed to actually contain and control Indigenous peoples around their culture and their identity by literally taking away your status, your identity as an Indigenous person. What we see also is that a part of the colonial strategies were the targeting of children. And this occurred in many ways through the residential school system, the 60s scoop, where Indian Affairs agents and others actually scooped children from their families, sometimes at birth in the hospital, and adopted them into non-Indigenous families as a part of the assimilatory process. And the ongoing overrepresentation of people of Indigenous youth in the child welfare system is another example of this. And these are just the heartbreaking photo of residential children at residential school. You know, as a healthcare provider, and I know some of you are working, this is a COVID-related project, so thinking about healthcare, it's really important as a part of the truth of reconciliation that we understand that healthcare has been directly implicated in these colonial policies. For example, it is well known that the smallpox was disseminated within Indigenous communities through the gifting of contaminated blankets to Indigenous peoples. The Indian hospital system was a separate hospital system set up to actually contain and control tuberculosis, which was extremely prevalent in Indigenous communities due to food insecurity and the starvation created through for many reasons. And so a separate hospital system was actually set up, and Maureen Lux's separate beds goes through this system in great detail. In those hospital systems, not only were Indigenous peoples it was at a separate system where just Indigenous peoples were treated. There was experimentation that occurred in those systems, and the quality of care was often substandard. There was nutritional experimentation that occurred not only in the Indian hospitals, but actually in residential schools. And that work was overseen by scientists and physicians and other providers. The ongoing forced and coerced sterilizations with the class action lawsuit that was just filed in 2019. The most recent person that signed on to that lawsuit had experienced a forced tubal ligation when she went in to give birth to her child in a hospital in the prairies in December of 2018. And there are countless other people who've signed on to that class action lawsuit because of these experiences, which are ongoing, by the way. I've been informed about someone who recently was sterilized against their will as well. And the prominent cases of Brian Sinclair, who went into the an emergency department in Winnipeg, was sent in to have his Foley catheter changed because it was blocked. He developed a change in his level of consciousness. The assumption by those in the healthcare providers in attendance was that he was inebriated, when in fact he had urinary tract infection that was progressing to sepsis. So he had a change in his level of consciousness as a result of that. He ended up dying from that. A condition, urosepsis, that could have been treated with broad spectrum antibiotics. So an example, once again, of a stereotype that did not just lead to substandard treatment. That substandard treatment or lack of treatment led to his death. And of course, the prominent case of the courageous Joyce Echaquan, who filmed the last hours of her life when she was having racist expletives and being treated with tremendous disrespect in a hospital in Quebec. Another framework that I want you to understand, or theoretical concept, sorry, not a framework, is that of historical trauma. And Dr. Maria Yellowhorse Braveheart described this in 1995 as an idea of collective suffering, memory, and trauma, and how it's applied to the experience of her people, the Lakota, and really understanding the collective nature of trauma. Of course, she did not come up with this idea. This was a concept that had been well known through scholars in the Jewish community and survivors of the Holocaust around intergenerational trauma and collective trauma. She described, though, in 2003, this historical trauma response, as she was a psychologist, which she describes as a complex of behaviors that include all of these things articulated here. But really important, as I said, is her understanding of this collective trauma, of how being a residential school survivor or being the child of a residential school survivor extends beyond just the individual who's experienced that, but to the whole family and the community. So thinking about how the deaths of Joyce Echequan and Brian Sinclair ripple out well beyond just their own families, but to communities at large as they observe this trauma and actually think about their own experiences in healthcare. I think important to remember that Indigenous peoples in healthcare suffer from these significant gaps, and they are across almost all major health indicators, including mortality, infant mortality, chronic diseases, with a whole host of evidence around, for example, later diagnosis and higher mortality from breast cancer among Indigenous peoples who get cancer, or a higher rate of amputation among Indigenous peoples with diabetes. So there's ample evidence around this, and how they are disproportionately common and higher among Indigenous peoples. And I think it's also important to remember how colonization not only inflicted traumatic violence through all of the residential schools and the other pieces that we've talked about, but they also disrupted the buffers for coping. And I like this Indigenous stress coping model because it points that out. So you've got traumatic violent action or disruptive acts, such as taking a person to residential school, and then you have disruption of those practices that would usually be protective, such as language, culture, spiritual practice, because of course all of those activities were banned by colonial governments. So that combination actually leads to the divergent health outcomes. And I think seeing it that way is helpful because it helps to understand where the points of intervention need to be as well. Just a reminder from this is the Royal Commission on Aboriginal Peoples in 1996. There have been report after report after report. Aboriginal people do not want pity or handouts. They want recognition that these problems are largely a result of loss of their lands and resources, destruction of their economies and social institutions, and denial of nationhood. They seek a range of remedies for these injustices, but most of all, control of their lives. And that is why we are talking about Indigenous rights and about self-determination, because self-determination is about control of over your life and over the life and over community and leadership and governance and all those other aspects of living, including health, including economic development. And as I said, one of the most important parts of anti-colonial practice is understanding that the gaps that exist now are directly related to the Canadian government policies, such as the Indian Act, the reserve system creation, the residential school system creation. So having given you some of those frameworks, I'm going to talk a little bit about the way forward and some suggestions. And I'm going to use what I call the wise practices approach, and that is distinct from best practices. And I think that this may resonate with the work that you're doing. And I'm going to just talk a little bit about the distinction. So, we're used to in academia, in healthcare, in medicine, in research, talking about, these best practices models. But we can't assume that what works in one situation, context, or culture will necessarily work in another. So there is no practice that is best for everyone in every situation. And this is why I think it's important to understand the difference between best practice and wise practice. In fact, I've just written a paper with with an amazing endocrinology clinician scientist in endocrinology about who gets included in the randomized control trials that we use to then establish best practices and the best evidence, and looking at all the groups who are excluded. This is, of course, not new to you as researchers, but I think this is why we need to start recognizing that we must look not just at what the evidence based on particular trials showed, but how does that get applied and adapted in certain contexts. The tools that are used, the processes and for evaluation are often built on non-Indigenous values and knowledges. The term best in itself is a hierarchical construct and often doesn't resonate with the Anishinaabe, for example, worldviews, where things of hierarchies tend to be a lot less hierarchical. And it can also, this idea of best practice can create a reliance on large, well-funded, academically directed studies, such as randomized controlled trials, and in so doing can ignore the expertise and knowledge of different forms of wisdom, different forms of science that have existed within communities for hundreds of years. So, and really this work is well articulated by Cynthia Wesley Esquimo and Brian Callioux in their paper from 2010 about Indigenous community leadership and development. And they cite Davis as that paper as describing wise practice by its very nature is idiosyncratic, contextual, textured, and probably inconsistent. It's not standardized, not off the shelf, and not a one-size-fits-all concept. I feel that this distinction is probably one of the most important aspects of the work that you are doing going forward. I'm going to talk about now, for the last few minutes, 10 minutes, some of the, a report that a policy document that I did. It was funded by the McConnell Foundation and recruited through an Indigenous steering committee that was a subcommittee of Healthcare Can, to actually guide healthcare leaders around how to implement the Truth and Reconciliation Commission's calls to action for healthcare. And so I'm not going to, I did, interviews with healthcare leaders in Indigenous health across the country, was guided by an Indigenous steering committee. And I want to acknowledge their incredible expertise here. And then came up with not quite a checklist, but a guidance document to help leaders in how to think about moving forward for reconciliation in their organizations. And I thought, given the work that you were doing, it might be helpful to articulate some of them here. First of all, as you're moving forward with the One Society Network, with any recommendations, policy documents, et cetera, specifically if you're working with, if you're referencing Indigenous health, you can't be going offside from what is already happening out there at the national level and the local level. So it's important to recognize what are First Nations, Inuit, and Métis leaders and their national organizations doing around health transformation, around COVID-related policy and pandemic-related planning, for example. You need to actually build strong community partnerships. So that means identifying who are the key stakeholders in the region where you're working, who are, whether it be a geographical region or an academic area, who is doing that work and who must you build relationships with. And remember, relationship building is like friendship building. It takes time, it takes commitment, and it takes authentic engagement. And these may include representatives from local and regional First Nations, Inuit, and Métis governments, local Indigenous health service organizations, Indigenous clients, Indigenous researchers, Indigenous scientists. So identify those people and work on those relationships. Also, make reconciliation and Indigenous health a part of the work in a very overt way. How are you addressing Indigenous health equity or reconciliation and self-determination in your strategic plan, in your work going forward? Around governments and leadership, we said that you need to promote the involvement of Indigenous peoples in your organization, in your research practice, in your institution, across the organization. So if we're looking at a hospital, for example, recruiting people to the board, nominating people to the board and supporting them, to the senior leadership team, creating advisory circles, hiring community liaison, looking at elders councils, knowledge keepers councils, other roles. And you must then have action-based accountability. So you're not just appointing people in tokenistic ways, but acting on recommendations that come forward. For those of you who are looking at, building your teams, are you hiring? Are you recruiting Indigenous and mentoring Indigenous staff across your team? Are you creating learning environments where they can thrive, where they are valued as Indigenous peoples, where their knowledge is valued? And the reason this is very healthcare specific, by the way, is this is word for word from the guidance document that we created. So this was really looking at hospitals and clinics, but you can see, I think, how these principles can be adapted more broadly. Make sure that you're doing your anti-racism and cultural safety education within your teams, that you actually have ways where the learners and others on your teams who may have experiences of mistreatment can come forward to report them and can feel supported in that. And at a larger level, how are you documenting these instances, tracking process, and being accountable to change? Supporting Indigenous learners in your field to make sure that the environments are safe and respectful ones that are free of discrimination. And lastly, and this is my last slide before we can get into a Q&A, or second last one, that where data is available, that we are tracking Indigenous health outcomes for Indigenous versus non-Indigenous clients in the organization. However, this requires data stewardship agreements that must be developed and followed. And this is where I want to flash forward to the seminar that you'll be doing next week on Indigenous data governance through the ownership, collaboration, access, and possession of data model. You can also look to the Tri-Council Chapter 9 agreements about how to work with Indigenous peoples and how one creates a partnership with an Indigenous stewardship group who will oversee any data that you are collecting about Indigenous peoples. They own that data. They must collaborate on its collection. They must have access to it whenever is necessary. And Indigenous peoples who offer to have their data enter into your research project have the right to withdraw that data at any point. This is very nuanced. It can be hard to enact, but it involves legal agreements with your Indigenous partners to actually spell that all out. I would also like to remind you that you can't start collecting data on Indigenous peoples until you have these agreements in place. And what you'll be doing next week is learning a little bit more about how to enact that in your work. It's really, really, really important. This is what's led to something like the Maori Data Sovereignty Network in New Zealand, where all Indigenous health and social data is actually governed under this larger sovereignty agreement and overseen by Maori leaders. Lastly, you can't really advocate for change related to pandemic care, related to economic development, or anything else without addressing Indigenous social determinants of health. And it is so critical to talk about not just colonization, but its downstream social determinants, such as food security, such as access to education, access to healthcare, stable housing, etc. And that really, when we look at tackling inequities, we must not just think about the point of care, but also this bigger picture of the social determinants. Oh, I do have a few more slides for you. I forgot I'd included these because of this being a research network. Anti-colonial and anti-research research is strengths-based rather than deficit-based. What are the strengths within the community? How are they working to address address inequities? What are the approaches to collaboration, to culture, to knowledge that are actually helping solve problems? It must be action oriented rather than passive collection of data that's just going to lead to the publication of another paper that demonstrates a health gap. How is research must be a tool for advocacy, so a tool for action and for change, and the responsibility one holds when you are doing research with Indigenous peoples. And these 4 principles are really important to remember, published by Kirkness and Barnhart in 2001. Respect, you must be respectful of the communities with whom you are working. Is the research question that you are asking relevant? What is the reciprocity? How will, if this research is helping you as a researcher, most importantly, what is it doing for the community? And what is your responsibility to ensure that it is all of these things: action-oriented, a tool of advocacy, and strengths-based? And, you know, Indigenous peoples are at a stage when they want research and research design to contribute to self-determination and liberation struggles as it is defined and controlled by their communities. An old quote, but beautiful and still relevant. And, you know, I'm not going to go through these changes in the Indigenous research paradigm. We've seen these changes over the last 35 to 40 years among Indigenous researchers or research for and with Indigenous peoples. But the current stage is that it is grounded in Indigenous knowledges, ways of knowing and being. And that's why it's a really exciting time for Indigenous research. And it's exciting to know that finally, as Steinhauer says here, our voices are being heard, and that Indigenous scholars are now talking about and using Indigenous knowledge in their work. It's time to give voice to and legitimize the knowledge of our people. Another classic quote from Marlene Brandt Castellano to end on: fundamental to the exercise of self-determination is the right of peoples to construct knowledge in accordance with self-determined definitions of what is real and what is valuable. This is why, as an external researcher, one cannot just go into a community and think that you know what the research question is, because the community and the partners and the leaders within need to determine what is real and what is valuable. So I'm going to end there. I guess I will stop sharing and open it up to Q&A. Ellen, I've given us 15 minutes as requested for that.
I was going to say, perfect timing. Very impressive. Thank you so much, Dr. Richardson. The whole description of the history and the foundational frameworks that really inform health and healthcare in Indigenous peoples was very, very enlightening to me, as well as the advice for our network around how to incorporate some wise practices. So I do encourage everyone to send some questions in the Q&A. I will, take advantage of being the facilitator and ask some of mine off the bat. So I'm curious if you've seen examples about how the pandemic has maybe changed the landscape of health or healthcare for Indigenous peoples. Has there been a big impact in, positive, negative way? What have you seen?
So a lot of the patterns actually mirror what we see on the larger level. So, but I'm going to highlight a few things. What we've seen, particularly early in the pandemic, was Indigenous innovation around community-based healthcare delivery, which was really remarkable. So I worked and have written about the experience of working with Anishinaabe Health on their vaccine outreach strategy. Anishinaabe Health is an Indigenous Health Access Center in Toronto. It serves the urban Indigenous community. And there was an understanding early on that Indigenous peoples in both on reserve and off reserve in urban settings, due to the social determinants of health, would be at higher risk of COVID and of complications of COVID. And so the anticipation of that and the need to actually be innovative and culturally responsive in the both the testing outreach and then subsequently vaccine outreach was truly remarkable. because it was saying, we want an Indigenous organization who understands the needs of our people to actually be going into community and not just testing for COVID, but also offering gift certificates for food, having a primary care practitioner available to actually answer people's questions and do some primary care, like, diabetes management, etc., that very much have an elder present or knowledge keeper present to support spiritual needs. So very much a holistic model of care is what was prioritized during COVID. And that is a brilliant model. And that, so that was an example of Indigenous innovation in response to COVID. It emerged because of a sense of the need to protect community, to protect elders and collective well-being. So although there was initially, in many cases, vaccine hesitancy because of the history of experimentation, including with vaccines, when you have Indigenous organizations leading this outreach who understand those concerns, who are able to create environments where there can be dialogue and thoughtful conversation about vaccines, for example, it really was a game changer in terms of the uptake of vaccines. So we did see very, very high uptake. There were pockets where it was low, but very high uptake overall of vaccines. We also saw tremendous advocacy by leaders like Chief Roseanne Archibald, who's now the AFN chief, around the need for early access of vaccines for Indigenous peoples. Then we saw, for example, for outreach to remote communities, meaningful and important partnerships between Anishinaabe Aski Nation. I'm sorry if I'm being Ontario-centric here. I'm talking about examples that I know. So Anishinaabe Aski Nation, that represents 40 plus Indigenous communities in the northwest of Ontario, partnering with Orange, which is the ambulance and transfer service, to actually bring providers into communities that were flying communities and vaccinate communities. And we saw, again, massive uptake. So that's number one, the innovation and the really remarkable partnerships and community-based development. So it meant that also, due to the self-determination and the fact that leaders and chiefs were often closing off borders and boundaries and had the right to do that because of self-government, communities in the first wave did very, very well. And we've actually written about that. Rates of COVID were lower than they were for the rest of Canada and non-Indigenous peoples in Canada. Unfortunately, we knew that once COVID got into community, it would be a problem, especially in areas where housing is inadequate. And that also did play out in the sort of January 2021 wave, where we saw real peaks of COVID and high rates of COVID among Indigenous people. It also played out due to the complexity and the higher rates of multimorbidity due to all of those reasons that I've talked about, where Indigenous peoples were more likely to be hospitalized. So we've got that data. For example, Dr. Marcia Anderson, one of my good friends who led that as a regional health officer in Manitoba, led the collection of data specifically for BIPOC and Indigenous peoples. And we did see that Indigenous peoples there were more likely to be hospitalized and have severe illness, and likely due to those that multimorbidity. Thirdly, what we have seen, which is what has played out in the rest of the population, is what it means when you've got delayed access to care. So when you take the existing delays in access and an underfunding and lack of mental health supports, chronic disease management, et cetera, and you add on the delays that occurred because of COVID, we've seen almost crises related specifically, I would say, to mental health. That, of course, is occurring not just among Indigenous peoples, but if there's a high prevalence and lack of access in the first place, COVID, as we know, has heightened existing gaps. And so that is what the evidence has supported as well. I hope that's a long-winded answer, Ellen, but I hope it gets at what you were looking for.
No, it's really interesting. And as soon as you talked about the vaccine example, I thought of Alberta. I know the Métis Nation of Alberta put together a similar kind of clinic, and it was very open to everybody, but it also incorporated some of their cultural considerations, and I think it really helped raise the rates of vaccination.
Yeah, and
Um,
that really did occur across the country. We saw that everywhere. It's so I just point to the specific examples because I want to locate myself and be clear. But it does, there are countless examples across the country of that.
yeah, and I think there's so much to learn from that. But thinking about what we could learn kind of as a community, when we're talking about modeling and economic analyses and these types of maybe more quantitative types of research, and thinking about how to do or incorporate that consideration of those foundational frameworks and maybe that reflexivity that you're talking about at the start of the presentation. I'm curious if you can think of any kind of concrete ways that we might be able to better do that as a community, because I know modeling wise, it's been very difficult, and I don't think we've done a good job of it. So I'd be curious if you have any thoughts on that.
Well, this is where I thought the wise practice versus best practice would come in. The models that if you're creating a model that is based on non-Indigenous peoples and populations, it's not going to be relevant in Indigenous contexts.
Right.
You're going to always, if you've already created that model, you're always going to be retrofitting, trying to make it work in Indigenous communities for Indigenous peoples. So when I talk about that distinctions-based approach and the inherent rights, this is why where contexts are so different. And you actually, unfortunately, I think need to develop Indigenous specific models, or you need to take the models that you're working with and the factors that you're putting into it, and you need to actually work with Indigenous partners and say, is this relevant? Is this meaningful? Is this actually even tracking outcomes that will be important to you? And if not, what else do we need to include? And how can we pilot it with you and understand its relevance, and then iterate it together?
Yeah, I think that tracking outcomes that are relevant to you is so interesting and so important, and not and something we do kind of poorly across the board, I think, but in particular in this area. I have a question. I don't know if the Q&A is working right now, but somebody sent me an email and they want to hear more about that data sovereignty that you talked about with in New Zealand, where they've kind of gathered all the data together in one place, and just to hear more about that. I think it sounds like a fantastic idea, and I don't know if it's achievable in Canada, but
well, yeah, it is. I mean, you're going to be doing the course for the First Nations Information Governance Center, which is the place that governs First Nations, a lot of First Nations data that's collected through regional health surveys. Okay, so you'll have an experience of that through that program that people will do next week. And I really hope that you do it, because really you shouldn't be passing ethics otherwise if you don't have data governance agreements in place and you're collecting Indigenous data. And we're becoming pretty hardcore about that, where we're actually saying to researchers, sorry, this is not appropriate as an ethical frame. You don't have an appropriate data sharing agreement in place. You don't have an understanding of that. So you're going to have to pause. Another example of how it plays out is actually here in Ontario, where the ICES data with the Institute for Clinical Evaluative Sciences, which actually holds all the a lot of our OHIP data on healthcare usage and outcomes, has relationships with the Métis Nation of Ontario, the Inuit Tapiriq Kanatami, which is the organization representing Inuit, and the Chiefs of Ontario. And any researcher who is seeking to access and do database linkages to understand and include Indigenous data actually has to put forward their research question and have it approved by the by those three organizations. So it's a very clear approach to make sure that the data is actually only used in a respectful way and is asking questions that are beneficial to community. Will we see a Métis, will we see a data sovereignty network regionally, nationally around Indigenous data similar to the Maori one? I think that we will one day. I think that FNIGC is a good example of that, but specifically for health data, for public health data, possibly we certainly need to be working towards models like that. And I think it will be distinct. Métis data will be distinct from First Nations data, which will be distinct from Inuit data. I know it's complicated and probably frustrating for researchers, but that distinctions-based approach is really important as well, especially because there are different outcomes too, depending on your nation and also region.
Yeah, that's really interesting. I didn't know that about ICES. So that's really interesting. I remember when they were called ISIS, and then they were like, oh, maybe we shouldn't use that name. Okay, so we have a question from Elena, and she says, "Thank you for the great presentation. I'm wondering." So this is kind of related to what we were just talking about, but just wondering how health researchers can ensure that that Indigenous people have appropriate level of ownership and participation. How best can we approach Indigenous communities in a way that is culturally appropriate and not burdensome for the community? It's always a concern.
Yeah, so this is where I go back to relationship building. You need to work on building those relationships with partners so that actually when you're coming up with the question that you want to ask, you are then working with your partner who hopefully build some relationship with, who can say, no, that, or come to one of our meetings and present that, and we'll see if it seems relevant. So that's one way if you have proximity to local First Nations or Métis communities or Inuit communities or health service organizations. A second way is actually to build an advisory or a reference. They're typically called a reference group. So to actually create through those relationships to have a group of a network of people who can guide and oversee the data. And typically the data sharing agreement is with those, would be with that reference group or with the Indigenous service provider organization. For example, Dr. Janet Smiley, who does a ton of Indigenous public health research, has partnership agreements with 7th generation midwives and with NAMERES, which are 2 Indigenous social health and social service providers in Toronto. And so they actually guide and advise and supervise and steward the data that she collects. And then she has a larger Indigenous reference group that helps work through questions as they emerge and data analysis, etc.
Great, thanks so much. Thank you for the presentation. Thank you for the discussion afterwards, and thank you everyone online for attending. The next seminar will actually be at a different time, just to note that. So it's typically on Thursdays at 10 a.m. Mountain Time. So feel free to register. I'll put the registration information in the chat here. The next one is on assessing trends and patterns of the effect of COVID-19 on public transit revenues in the city of Calgary. And that's by Dr. Ted and Ms. Yu. So please attend, and looking forward to see you there. Thank you, Lisa.